Hello everyone. What abnormality do you see on the strips on the screen? Go ahead and pause the video and think about an answer. In this session, we'd be talking about a few variants of a normal EKG as well as a few artifacts. It's extremely important that when you're interpreting an EKG, you do so in the clinical context. You try and compare it with a prior EKG when it's available, and you look at the EKG and how it changes over a period of time. To make the best use of your time, go ahead and pause the video at the start of every scenario and pick out every abnormality that you see. So let's start off with the first case, shall we? This is a 20-year-old who presents with chest pain after a workout. The pain seems to be reproducible on your exam. So if you look at the EKG, the rate is about 75 to 100. The rhythm appears to be sinus. The axis seems to be normal. And when you look at the wave segments and intervals, notice that there is this characteristic notching in leads 2, 3, and AVF. And also, when you compare it to the baseline, which is the TP segment, you can see that there is a slight ST elevation, and this is pretty obvious in leads 2, 3, AVF, and also it's pretty obvious in V2, V3, V4, and V5. Now, if you're wondering what this specific wave is, it's just the intersection between leads AVL and V2, and it doesn't really mean a whole lot. However, when you look at the TP segment and then the ST segment, the elevation is pretty obvious in the leads that we've just mentioned. In addition, notice that for the most part, the QRS complexes and the T waves are concordant, meaning they're pointing to the same direction. The findings that we see are typically seen in younger individuals and are called early repolarization changes. Now, compare what you've just seen with the next EKG, which is a 40-year-old who presents with chest pain. So this EKG is that of a 40-year-old otherwise healthy individual who's presenting with chest pain. When you start interpreting the EKG, notice that the heart rate is just under 100. Now, it's not really very high, but then it is high for someone who's otherwise healthy. The rhythm appears to be sinus. The axis of the P and QRS waves seem to be okay. And when you're looking at the waves intervals and segments, notice a few things. There is some notching, most obvious, at the end of the QRS complex in leads 1, 2, V3, V4, V5, and V6. Like in the prior EKG, relative to the baseline, you can see an ST elevation, and this is present in multiple leads. Additionally, we see T-wave inversion in V3, and more importantly, notice how in several different leads there is slight depression of the PR segment. For instance, we've just shown it in AVF, and also notice that in V3, where relative to the TP segment, you see slight depression of the PR segment. Also notice that in lead AVR, you see PR elevation. So relative to the baseline right there, the PR is very slightly elevated. So these are characteristic findings that you would see in someone that has early repolarization, as evidenced by the notching at the end of the QRS complexes, and on top of that also has pericarditis. So the characteristic findings that you're looking for here would be diffuse PR depression in most leads, as well as a PR elevation in lead AVR. Also notice that the degree of ST elevation is higher than you would expect in someone with early repolarization abnormalities. One other thing to notice how the ST elevation is predominantly concave upwards. In fact, if you were to complete a circle, you would almost see a smiley face. Similarly, even with pericarditis, you can see that the elevation is concave upwards. Now, contrast this to this EKG, which is that of a 75-year-old presenting with chest pain. So, in this person, the rate is approximately between 75 and 100. The rhythm is sinus, the axis is about normal. And when you're looking at the waves intervals and segments, notice how in leads 1, so 1, AVL, V2, V3, V4, V5, and V6, you see ST elevation. On top of that, notice how the elevation is predominantly convex upwards, and also it's pretty hard to separate out the T wave from the ST segment, and also the QRS, the ST, and the T waves are almost merging together, as in this case. So in essence, you're seeing that there is significant ST elevation that's primarily convex upwards. And also notice in the opposite leads, so in essence in leads 2, so 2, 3, and AVF, you see that relative to the baseline, there is ST depression. So when you see these characteristic changes, so you look at ST elevation that's convex upwards, and in reciprocal leads, you see ST depression, you would want to be worried about ST elevation MI. So, unlike in early repolarization and pericarditis, the ST elevation is convex upwards, and you also see reciprocal changes. Now, obviously, interpret the EKG in a clinical context. Sometimes what appears to be early repolarization might actually be a myocardial infarction. Now, let's look at the next individual who's a 50-year-old asymptomatic male with no prior history. So, looking at the EKG, the rate seems to be about 100 or slightly less than 100. The rhythm appears to be sinus. For the axis of the QRS complex, you don't have the limb leads or the augmented limb leads, but the P wave from the way it looks in V1 seems to be okay. And notice how in multiple leads, the T waves are either flat or minimally inverted. When you see these and there's nothing else to explain these findings, you call them nonspecific Stp changes. Now, again, this must be seen in the appropriate clinical context. For instance, if you saw the exact same EKG with a prior EKG that shows good T waves, and now the patient were coming in with chest pain, these could be coronary artery disease. So it's very important that you interpret an EKG in the clinical context. Next, get to the next EKG. This is an 18-year-old with chest pain after a workout. So again, the rate is between 75 and 100. The rhythm is sinus. The P wave axis is probably okay. Again, notice that we do not have the limb leads or the augmented limb leads. But then notice how, looking at the waves intervals and segments, you notice that the T waves are inverted in V1, V2, and V3. The inverted T waves in V1, V2, and V3 are normally seen in kids and sometimes can persist into adulthood, and they're called persistent juvenile T waves and are considered okay. They're usually not very deep, and they're limited to leads V1, V2, and V3. So let's look at the next EKG. So this is of a 60-year-old who's found unconscious in snow. So the rate seems to be less than 30. The axis seems to be okay. The rhythm is a little tricky. Notice how the baseline is not even. In other words, you can see that there are very frequent ups and downs, and also there's some semblance of what looks like a P wave. So this is likely sinus bradycardia, and the uneven baseline that you're seeing is likely related to underlying shivering. The axis seems to be okay. And when you look at the waves intervals and segments, note this characteristic notching again. You see these changes in multiple leads, and these notches are called Osborne waves. The profound bradycardia, along with shivering and Osborne waves, all suggest profound hypothermia. Now let's look at the next EKG. This is a 70-year-old with frequent falls. So starting off with the rate, it's just under 50 beats per minute. In terms of the rhythm, notice how it appears that the person's EKG just seems to be moving with no specific pattern. This is usually seen with atrial fibrillation. Also notice how the QRS complexes are fairly regular. If this is all you see, it might look like atrial fibrillation with a third degree heart block and a junctional rhythm. However, upon close examination, notice that you can see P waves in V3. So this person with frequent falls likely has sinus bradycardia along with underlying tremors, and given his history of frequent falls and the tremors that we're picking up on the EKG, maybe there's underlying Parkinson's disease. The axis seems to be okay, and when you're looking at the waves intervals and segments for the sake of completion, notice that there are T wave inversions in 2, 3, AVF. The QT appears to be slightly prolonged, but then this could be just in the setting of bradycardia. And lastly, there is some ST segment depression or elevation in multiple leads. And again, based on the clinical context, all these may be just non-specific changes. So to quickly review everything we've seen, early repolarization abnormalities are typically seen in younger individuals, and you see mild ST elevation, particularly in leads V2 to V5. There is the characteristic notching that you see at the end of the QRS complex, and usually the ST elevation isn't very pronounced and it's concave upwards. When you're looking at pericarditis, the ST elevation is still concave upwards and seen in multiple leads, but usually the notching is absent and the ST elevation is more pronounced. In addition, you might see PR depression with multiple leads with reciprocal PR elevation in lead AVR, as you can see in the EKG. In acute myocardial infarction, the ST elevation is typically convex upwards, and you would also notice reciprocal changes in the opposite leads. If you see mild ST and T wave changes in someone with no concern for underlying heart disease, you call them nonspecific Stp changes. Young individuals might have T wave inversions in V1, V2, and V3, and this might be a normal variant. Both shivering and tremor can cause the baseline to be very uneven and make determining the rhythm a challenge. Always try and figure out those subtle P waves that you can find on close inspection. I'd like to thank Life in the Fast Lane for allowing me to use their EKGs. If you are trying to learn more, it is an awesome website. And as always, thank you for watching.